welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. Welcome to Menopause Rescue. I'm your host, Dr. Polly Watson, and I am delighted to be joined today with Kate Willis, who is a nurse practitioner. She is a Menopause Society certified practitioner, and she is also certified in functional medicine by the Institute for Functional Medicine. So before Kate joined our practice, she had worked in dermatology, which makes her especially qualified to be our guest today and talk about hair loss, because this is something that comes up a lot in clinic, and women are really searching for answers and spending a lot of money on products online that may or may not work very well. So we are so excited, Kate, to have you with us today and hopefully shed a little light and maybe bring a little bit of relief, because I think this is such a anxiety-provoking topic also.
It's super anxiety provoking. And as we talk about treatments take a long time to work generally, and that can be really frustrating. And so I think patients struggle with knowing if they're even on the right path when they are doing something. So hopefully this can shed a little light on, what's happening, how do we evaluate this, what are the options, conventional and otherwise.
Well, perfect. Let's dive in. So let's start off by kind of clarifying different types of hair loss and how do you figure out which type you might have?
Yeah, great question. I'm going to focus on two main types of hair loss. So you can have an autoimmune condition, alopecia areata. I'm not going to speak as much about that. That's autoimmune and usually pretty significant hair loss that comes with that. The two types I'm going to talk about today are pretty common types of hair loss: telogen effluvium and androgenic alopecia. And I'm going to break those down a little bit. So telogen effluvium is the condition where hair follicles enter the resting phase of their cycle too early. About 80 to 90% of our hairs should be in the growth phase at any given time. And this growth phase lasts for a long time, like 3+ years. Conditions that cause stress on the body. So this can be things like hormone changes. So think postpartum hair loss. This can be medication induced. It can be psychosocial stress. It can be caloric restriction. It can be thyroid issues. It can be a nutrient deficiency, like an iron deficiency. We think about these GLP-1 agonists. They're causing rapid weight loss. These can be, potentially inducing telogen effluvium as well. And the confusing thing about this is the hair loss starts about 1 to 3 months after the event. So if you go through a really stressful period, or, you have a baby and, you don't see hair loss immediately after that event, it is in the next couple of months. So sometimes this can feel really confusing and figure out like, what's causing this? Like, I'm not stressed, or I'm not, losing weight, or whatever the, initiating factor might be. So know that it's coming after the event. This is really diagnosed by patient history. You can also do something called a hair pull test, which is just you pull, 20, 30, 40 hairs kind of a little bit and tug it. And really a negative test is when like less than 2 hairs fall out. So it's just a few number of hairs really should fall out if tugged. Now that doesn't necessarily differentiate from androgenic alopecia, but it's one of the tools we use in addition to patient history. Go ahead.
Well, I just wanted to add that in this kind of post-COVID age, we have seen so much hair loss after COVID. And just like you were saying, women are, you're like, oh yeah, I was sick a few months ago, and you don't really think about it. And then they come in, and then they usually they used to bring you the Ziploc baggie of hair, right? And now they'll bring you a picture of this is how much hair is coming out. But like, imagine you're holding your hands out like a bowl and there's that much hair in the shower drain. Like it's sudden but we're seeing a ton after COVID. And so that's just something to kind of keep in mind with COVID, RSV. Sometimes the stressor is an illness.
Mm-hmm. Yeah, that's a great point. And, if someone has thick hair and we don't visibly see a lot of hair loss, I think as providers, we need to remember, pay attention to patient
Mhm.
history. Patients know how much hair they normally lose, and they know when that changes. And so that's a really important part of figuring out what's going on, listening to the patient and trusting that they are understanding that something's happening with their body.
Kate, can I ask you a quick question? Just because, like, you started off by saying so many women are frustrated, understandably. One, because maybe they don't feel like their providers are listening or really taking this as seriously as they
Mm-hmm.
feel it is in their lives. But two, it takes a long time to notice a difference,
Mm-hmm.
right? 3 to 6 months. Do you ever have people take photographs of like a middle part or like when you pull the front of your hair up so you can kind of monitor changes? Would you recommend that to people so they can have something objective to fall back on?
I do. It change is very slow, and so I think when we look in the mirror at ourselves every day, we're not seeing those changes. But having some sort of objective photo, or of the area where they have been
Mhm.
having hair loss. Sometimes,
Mhm.
if it's more of a generalized hair loss, it's hard to notice if it's improving through a picture. But if I think androgenic alopecia is probably actually easier to track with pictures because it's happening. Hair loss is happening in a particular pattern versus telogen effluvium is more generalized hair loss. But I do think photos are a great help for people in monitoring progress. Um, yeah.
So let's segue right into androgenic alopecia, or
Yes.
some people might call that male pattern balding, and we also call it female pattern balding. So maybe you can kind of decode that for folks.
Yes. So this is something that has a very strong family history. So if you had a mom or grandmother or aunt that had some hair loss, you might be more prone to this. We do the male pattern is typically receding in the front scalp. So you'll see sort of this like, you know, bigger forehead, receding hairline. And female pattern is more widening along the part line. And as this progresses, we actually call it a Christmas tree pattern. So it'll be kind of more narrow in the front, wider in the back, and can progress to more hair loss over the crown. So there are two kind of different patterns, but they're both being driven by the same underlying mechanism. What's interesting is that telogen effluvium can uncover this hair loss for a lot of people. So sometimes people will lose weight or have a stressful event or have an illness, and then they'll start to see this hair loss happen, and it kind of
Mhm.
uncovers what was going on before. In this type of hair loss, the hair follicles are slowly shrinking until they stop producing hair. So what you'll see is this, what we call miniaturization of the hair. So the hairs are getting smaller and smaller in size. So that's something to pay attention to if you feel like maybe you're not shedding a lot of hair, but your hair is just getting a lot thinner in certain areas. That's something to pay attention to. Kind of the mechanism here is that the hormone testosterone is converted to something called DHT by this 5-alpha reductase enzyme. Essentially, DHT, this metabolite, has a stronger affinity for the androgen receptors, and so that can stimulate more androgen side effects like hair loss. So that's kind of the underlying mechanism of what's happening.
And I think it's important maybe to point out, like, we might even think about women with PCOS that might have higher androgen or higher testosterone levels. What the testosterone level that's going on at the scalp may not be reflected in a serum blood draw. So that can kind of compound
It,
the confusion and the frustration of what we're seeing on blood work may not actually be representing what's happening at your scalp. So
Absolutely. I've had patients come in and they're like, I think maybe my testosterone is too high. And the frustrating thing is that androgen excess doesn't always show up on labs. Sometimes we are seeing that on labs. We're usually seeing maybe some other symptoms associated with that too. But if you have this sort of family history and genetic predisposition, um, you have these receptors at the scalp site that are just gobbling up that DHT and leading to this hair loss. So labs are not always helpful to diagnose androgenic alopecia.
Right, right. But you
Yeah.
mentioned something that I think is important and not like completely related to this, but adjacent. And that, so women may be listening to this and maybe like, oh, wait, maybe I should be afraid to take testosterone because I have a history of male pattern balding. So can you kind of talk a little bit about that, if that history would make someone want to hit pause on that part of their menopausal replacement plan?
I think my advice would be to go slow,
Hmm.
because absolutely, if you have an increased family history or if your levels get a little bit too high, that could stimulate some hair loss. I've seen that happen with some patients. So going slow is a really great way to be on the lookout for any high androgen symptoms, getting acne along the jawline or getting hair growth on the face or seeing some changes in hair. Absolutely. I think that's not a barrier. It's definitely not a no. It's just something to be thoughtful and to really work up slowly in dosage.
Yeah, and so like I think if that in that decision making process, I would highly not recommend someone go get a testosterone pellet where they were getting a fairly high dose that they were going to commit to 4 months
Yes.
versus a transdermal gel or a cream that they can, like you're saying, start low, work up slow, so that if there is something going on, you can catch it and back off real quick.
Yeah. The situations where I've really seen the most hair loss have been in individuals who got pellets and
Hmm.
had higher levels and couldn't do anything about that for, several months.
Right.
And it's really spurred some hair loss on.
Yeah, yeah. And then maybe just one thing to distinguish between telogen effluvium and androgenic alopecia, and I think you said this, but I think it's really important to clarify for folks, is that the telogen effluvium used is generalized and it's usually kind of all at once,
Hmm.
whereas the male pattern balding or the female pattern balding, the androgenic alopecia,
Hmm.
that's the word I'm supposed to use, it's more slow, right? It's more gradual.
It is, and it's telogen effluvium will usually, when the stressor ends or if the nutrient deficiency is corrected, or as someone, if you have COVID and that's what stimulates telogen effluvium, generally we'll see that stop and we'll see the hairs move back into that growth phase.
Mhm.
Whereas, correct, androgenic alopecia is a little bit more slow, insidious, progressive type of hair loss. So yes, great point.
Let's talk about testing a little bit because I think it's a little confusing. And
Mhm.
then yeah, so let's say I come in and I'm like, "Hey Kate, my part's getting wider," or I bring you the little pile of hair. I
Yes.
can't tell you how many people,
Yes.
women, have brought me little piles of hair. Thank you so much.
Yes. We
Um,
usually don't need to see the hair, but I do think patient history is really important, and I said that. We're losing hairs every day. A normal head is losing hairs every single day, and our head is keeping up with hair growth so that we aren't having, in a normal situation, we're not having hair loss or thinning hair. We lose more on days that we shampoo, so but if someone notices that they're having more hair, like patient history is usually pretty reliable here. We don't actually notice hair thinning until about 50% of our scalp density is lost, which is
wow.
a lot.
Hmm.
So I think it's important to be paying attention to patients and be really moving forward with a solution before they're seeing visible hair loss or hair thinning. In terms of blood testing, a complete blood count that looks for anemia and a serum ferritin. So, ferritin is the iron storage protein. Those are important. If someone has frank anemia, meaning their hemoglobin and hematocrit is low, that needs to be corrected with iron.
Hmm.
But if their ferritin is low, and ferritin is not something that's routinely checked on annual labs, if ferritin is low, even less than 50, or some people say even more than that, is correlated with hair loss. So
Hmm.
I know you do too. We see women all the time who come in and they have a ferritin of 6 or 10 or 12, and they're not anemic, but they are, having symptoms related to that. A serum ferritin of less than 15, which is not uncommon to see in practice. Those individuals are 2 times more likely to have hair loss associated with that level of ferritin. So I think that's a really important one to be testing.
And it's the one that I'm always excited when I find, because it's like easy to
You can do
fix. Like,
something.
you are immediately a hero. You put them on iron and 3 months later, like, oh my God, it's better. And I'm like, but I think it's another kind of point to sort of interject. So many women at perimenopause are having all this irregular heavy bleeding sometimes. And so if you're losing more blood and you're not replacing that from a dietary standpoint, maybe you don't eat meat, maybe you don't eat a lot of dark green leafy vegetables, maybe you're having a ton of calcium that's binding your iron so you can absorb it. Serum ferritin goes a long way, and it's really easy to fix. So that's great news.
Yes. Vitamin D is important to measure. So vitamin D supports the growth phase. What's interesting is that vitamin D supplementation, we don't really have evidence that it improves hair loss, but it's something that I'm thinking about in the big picture of making sure that hair is growing and keeps growing. So it's an important one to check. Thyroid, hypothyroidism can lead to hair loss. There are a couple of mechanisms. Hypothyroidism can induce telogen effluvium. Also, patients who have androgenic alopecia also have a higher prevalence of thyroid disease and positive thyroid antibodies. So those two things are associated with each other. So thyroid is at the top of my list of labs to evaluate for an individual who's having hair loss. Prolactin, so if prolactin levels go high, that can inhibit hair growth. Blood sugar is important. So blood sugar, hemoglobin A1C, and elevated insulin. So we think here the mechanisms are inflammation, potentially from elevated insulin levels. There are some studies that point to, this is particularly with women who have PCOS, but if they have a hemoglobin A1C, which is that 90-day average for your blood sugar, they have a hemoglobin A1C that falls in the pre-diabetic range, 5.7 or above, that's actually associated with more hair loss. So again, kind of something that doesn't probably get looked at often when hair loss is the conversation, but I think that's an important thing to have on your radar.
But so important also thinking about that perimenopause transition, right? So not only are our estrogen, progesterone, testosterone levels changing, we were becoming more insulin resistant typically. So that number, we may be eating the same and exercising the same, but we may be creeping into that pre-diabetic range. And we're thinking, oh, it's because I'm perimenopausal, but it could also be a blood sugar issue. So looking at all the things is so important.
Yes. Celiac disease. So if you have celiac disease, stopping gluten consumption can improve androgenic alopecia. Interestingly, now we don't have studies that for individuals who don't have celiac disease, even if they have a gluten sensitivity, that's helpful. I think it could be. We just don't have the data to back that up. But making sure an individual does not have celiac disease. If a patient is younger than 25 and losing a lot of hair, an ANA is something that is reasonable to check. This is rarely positive in old, women in kind of midlife. And so I'm would be interested if a history, was hair loss started years ago, that would be something to consider. But if hair loss is more recent, I may or may not do that based on patient history.
So just to clarify for folks that maybe aren't familiar, an ANA would be a test that's often kind of the beginning of a lupus workup. So you're thinking about other autoimmune conditions.
Yes. Thank you. Okay. And then, hormones, we sort of already touched on this. This seems like this very reasonable thing to test my hormones and see, if there is, an elevated level, or is it declining estrogen that's contributing. There just isn't a strong correlation between hormone levels and androgenic alopecia or even telogen effluvium. We think that the ratio between estrogen and testosterone as it changes in perimenopause can be part of what's stimulating some hair loss for people. But again, there's not this like level or a ratio that we're looking for, or does replacement of hormones, testosterone or estrogen, seem to improve hair loss? So it's a little muddy. I'm often checking hormones for other reasons, but it's probably less helpful in this setting. Now, the one caveat I would say is that the Dutch test that we both use, gives us some information on the androgen side. So it's telling us a little bit about those androgen metabolites. It can give us some clues that there may be trouble with androgen metabolism, or that there are some specific ways to support a patient. But I'd say hormones in general, especially on blood labs, are not the most helpful information.
Right, because what's going on at the level of the scalp is not always reflected either in the serum or, in the case of Dutch, urine metabolites or saliva. And then I've always thought that it's not just the hormones, but the hormones plus inflammation, right?
Mm-hmm.
And so when you're talking about doing a Dutch test, you're looking at that androstenedione, that testosterone precursor. And if it's going down that 5-alpha pathway, that's usually associated with a lot more inflammation. So
Mm-hmm.
again, if we're thinking about differences in hormones and inflammation seem to be more of a problem, that can be a real tip off. But I think this is giving a great picture that it's not super straightforward. There are a lot of things to check. And stress, you mentioned, is hard to measure, right? We can measure,
So hard.
like, we could do a Dutch and look at cortisol metabolites and a cortisol awakening response, and that's going to reflect what happened that day, but isn't going to reflect what happened 2 to 3 months ago when the hair loss started. So it really is a tricky thing to kind of tack down.
It is. It is.
Well, that was super helpful. So when we think about, like, okay, what do we do now? We can get some labs. There are some straightforward things, like if ferritin's low, we can fix that. Vitamin D is low, we can fix that. But if someone's like, okay, I'm in charge of what I'm putting in my mouth, I'm in charge of how I'm hopefully managing my stress, whatever, what lifestyle things can people do?
So first, specifically with telogen effluvium, eating enough calories and enough protein. And this is, I know this is really hard in midlife if there's weight gain and someone's trying to lose weight. But if you are, dieting, if you are on a GLP-1 agonist, if you are not consuming sufficient protein, that may be a big driver of this telogen effluvium, and wanting, really giving your body the proper support. That I protein especially, I can't stress how important that is to
Mm-hmm.
really give your body the building blocks for hair that it needs. You mentioned, iron deficiency, which we've talked about. If iron deficiency is at play, focusing on iron-rich foods. This can be animal products, red meat. It can also be leafy greens. But you can do things like cook in a cast iron skillet too to increase your iron consumption. I do, if you're going to take iron supplements, my caution is that you don't take that blindly, that you work with a practitioner to monitor your levels, because if your iron gets too high, that is problematic in a whole nother way.
Mm-hmm.
And so you want to make sure that as you're supplementing, you're doing correct supplementation and that you're getting the right levels. But iron deficiency, like you said, is a really it's almost exciting to catch that on a lab, because you think this will change. Like we can do something about this. So I agree with that sentiment. If the thyroid is at play, you obviously getting the right thyroid hormones as needed, but what you're also trying to do, the thyroid mainly makes T4, and the conversion to T3, which is the body's most active thyroid hormone, happens outside of the thyroid. And so the liver is a really important site of that. You want to make sure that you're getting the right nutrients for that process to happen. So we think about things like sufficient zinc, sufficient iodine, sufficient selenium, getting you don't need excessive amounts of things, especially, like iodine can be toxic to the thyroid in high amounts, but you need to be getting a little bit of iodine, a little bit of zinc, some selenium every day. And then detoxification, essentially if the liver is not working well, conversion from T4 to T3 will be impaired. And so eating lots of plants, we want a very plant-rich diet to provide all those micronutrients that help with that conversion process. And then avoiding things that interfere with the liver working well. So things like excessive alcohol or added sugars or refined carbohydrates really impair the liver. So letting your thyroid do what it is supposed to do, and giving it the right nutrients to be able to do that.
Yeah, absolutely. And then maybe just, understanding how powerfully stress affects our body. Like,
Mhm.
it's so easy to say, like, oh, just do breathing exercises, but maybe just spending some time in nature every day, something where
Mhm.
you unplug, you're not listening to the news, you're not doom scrolling. Our brains were not meant to live in this sea of constant stimulus. We have
Mhm.
really robbed ourselves from the quiet that we need to really heal our brains. So
Yeah.
maybe stress management doesn't have to be complicated. It maybe doesn't have to be, driving across town and going to yoga. Maybe it means you
Mhm.
just walk around the block in your neighborhood and listen to the birds and just unplug for 20
Yeah.
minutes, right?
Yeah. Even, sort of anticipating if you know that you're entering a stressful season with aging parents or kids or work or whatever it is, maybe even on the front side of things, doing what you can to provide yourself some extra buffer to even prevent this from happening um, in the first place, and make sure you're
Hmm.
nourishing your body really well during that stressful period. Um,
Yeah, absolutely.
Wanted to just add in, I mentioned sort of this like, blood sugar issue. So working on blood sugar control, working on insulin resistance, if that's part of the issue, um, I think is really important. It does help lower inflammation and can potentially support better hair growth and recovery of that growth phase.
Hmm. Yeah. And everything else, right? If we can control our blood sugar, heart health, brain health, bone health, cancer, I mean, like we can do so much. So, appearances aside, control your blood sugar.
Yes.
So, let's move on to treatment. Like, if we're going to think about, okay, I've done all those things and maybe I'm not where I would like to be, what in the we're going to kind of first talk about conventional treatment and then we'll move on to more holistic or integrative
Mhm.
treatment. So let's start with the conventional treatment. What do we got?
Yeah. So conventionally, minoxidil, commercially known as Rogaine, there are lots of other manufacturers too, is a pretty decent, well-studied option. So it's available as a 2% and 5%. The 2% is like what's advertised for women. I don't think I've ever recommended the 2% to a woman. The 5% works better for everyone. So we should get the same good treatment that is available to a man as well. So the 5% treatment once daily is what can be used for hair loss. This is specifically helpful with that androgenic alopecia. So it's not necessarily going to end telogen effluvium, but it's really helpful in the androgenic alopecia setting. What's hard about Rogaine or minoxidil is you can actually see increased shedding for the first 8 weeks.
Oh,
And so
wow.
I want people, every time I recommend this, I'm making sure that people know that it might get a little worse before it gets better. Because if
Hmm.
someone starts a treatment and they see more hair loss, they think, what this is
Right.
doing nothing for me.
Hmm.
So know that it can cause a little bit of extra hair shedding at the beginning, and it can take 4 to 8 months to see regrowth. And so again, that's a long, long time to be waiting. We talked about potentially taking some photos of the areas where you have hair loss to see progress over months, because you're certainly not going to see progress very quickly or even from week to week. There are two preparations that are commercially available. There's a foam and there's a solution, like a liquid.
Hmm.
Um, the foam is nicer in hair bearing areas. And so some people prefer the foam. I think the dropper is actually probably easier to apply because you can literally drop it in multiple places and then just sort of rub it in. But then you have kind of wetter hair than the foam. The foam generally is not quite as yucky. So personal preference on that. You can also get this compounded if you're concerned about any of the additives in the commercial products. They're not perfect. Some are cleaner than others. And I think just read the labels and see what what you feel like you're comfortable with, and what if you're sensitive to any of those products, know that you can pursue a compounded option.
Can I ask a question?
Mm-hmm.
Okay. So I have two questions. One is just kind of like thinking about they're a working professional, right?
Mm-hmm.
So, and I'm imagining this needs to stay on the scalp for as long as possible. So
Mm-hmm.
would you and if you get up in the morning and you put foam on your scalp, I'm imagining your hair does not look fantastic. So
No.
are you advising people come home from work, take a shower, then put the stuff on their hair and it sits overnight? What is the best strategy here?
I usually recommend that people do it overnight, just because
Okay.
you don't want to put it on and then wash it off in
Right.
30 minutes.
Right.
And also, if you do apply it in the morning, though, I mean, you can absolutely take a hair dryer and dry the places that got wet. It's not a large quantity of
Mm-hmm.
solution. So when you're doing the solution, it's about 1 milliliter of fluid that you're kind of putting in the areas of hair loss. So it's not like getting your hair wet in a shower. But
Okay.
yes, thank you for clarifying. It does need to stay on for an extended period of time, hours preferably, before it's washed off. So I usually have patients do it in the evening, just because, if they take a shower and dry their hair, or you know, let it sit overnight without washing it off.
And then what about if you use minoxidil and then you stop? Is it true that you're going to have the hair loss you would have had while you were using minoxidil kind of all at once, or is that just an internet myth?
No, not all at once.
Okay.
But you're going to not see the improvements that you were seeing. So you're gonna start having hair loss again pretty quickly.
Okay.
So
Okay.
it comes back. Oral minoxidil is another option. So this same medication that you can use topically, you can also take it orally. It's a
Right.
small dose for women. With minoxidil, and I didn't mention this with the topical, side effects are that you can have hair growth in areas where you do not want hair growth. So you need to be really careful about applying the topical, that you don't get it on your face or get it, in an area where you're not wanting hair.
Mm-hmm.
That is a more of a potential side effect with oral minoxidil. It's not happening to most people who take oral minoxidil, but it is more common with the oral form. It's reversible, it's dose dependent. And so that's why we want to dose lower for a woman. And if you get some hair growth somewhere that you don't want it, you can stop the medication and do something about that, and it'll go away, which is great.
Okay.
This medication potentially has a side effect of weight gain, some low blood pressure, potentially some cardiac symptoms that feel like chest pain. So, I think this is not a medication just to take lightly. I think, you need to have a provider who's comfortable using it and, aware of the side effects.
And again, with the oral I'm still thinking that any of these are kind of a commitment, right? Because if you're using it for androgenic alopecia, that's genetic. It ain't going away, right? And so it's sort of like, no, this is part of your regimen that you're kind of on this.
Correct.
When I looked it up, the oral minoxidil, I think the hypertrichosis, the unwanted body hair that would happen elsewhere, I think it was around 13-15%. I don't know, when I looked up that stat, if it had anything to do with duration. That would be interesting if you were like, okay, if I use this product for a year and I'm not getting unwanted hair growth, then I've dodged that bullet. Or is it dependent on the length? And I just don't know that we know that.
I don't know that either. I do know that dose matters. I don't know if duration makes a difference.
Okay. Yeah. But it got really popular. I think the New York Times did an article on oral minoxidil, and it's gotten really, really popular. But that's helpful for people to know, right? So you want to work with someone, again, start low and work up slow, and be aware that, if you already had low blood pressure and were dizzy when you stood up, then maybe there would be a time to hit pause and do a topical formulation.
Yes. Spironolactone is another option that we can use orally. This is working by preventing the androgen production in the adrenal gland. It's also working to block the action at the receptor sites.
Right.
You need a relatively high dose of this for it to be effective. And again, all of these treatments are taking many months to see an effect. With spironolactone, I think about 6 months to really see a full effect, or a noticeable effect is reasonable. Lower doses I know are given often, that the studies that we have now just show that they're not that effective for hair loss for this androgenic alopecia. And they have side effects, so potential side effects. These are potassium sparing diuretics, or excuse me, increasing potassium, because they are keeping potassium in the body. Potential weight gain, you can have breast tenderness, you can have muscle cramps. This can impact libido because of how it's influencing the androgens in the body. Potentially some vaginal dryness. These are medications that can work, but they are medications that potentially have some big side effects.
Right. And then you mentioned the vaginal side effects. I think they brought up in Menopause Society this year. So just to make sure people understand, we have both estrogen and androgen receptors in our vestibule, sort of the opening to the vagina area. And so a lot of times when a patient comes in and says, I have vaginal dryness, her practitioner will give her estradiol. And unless those androgen receptors are being addressed, the problem won't get fixed. Mm-hmm. And so you could either compound estrogen testosterone, or you could use vaginal DHEA, but the DHEA would address the androgen receptor, as would the testosterone, and fix the problem. So we don't want people to try to fix one hair problem and cause another sexual pain problem.
Yes. One other topical option that is cheap and easy to try is topical ketoconazole shampoo. So this is actually working by reducing inflammation at the scalp. So part of that whole androgenic alopecia is this inflammatory state at the scalp. And so it reduces inflammation, and you want to use it at a 2% formulation. So you can get this over the counter. You have to leave it on for several minutes. So you're shampooing, obviously you can't leave on your shampoo overnight, but you want it on for at least a couple of minutes. Again, this is another treatment that is going to take months and months and months to see an impact, but leaving your shampoo on for a couple of minutes in the shower might feel easier than committing to putting some solution on your hair every night. So I think that's a really reasonable option for someone to try.
Great. Any other conventional options before we move on to more holistic options?
Well, PRP is sort of, I'm not sure whether to put that in the conventional or the integrative. I know you had a discussion with some dermatologists about PRP, and so you may actually know more than I do about that, but I think there's pretty good data for some people. My understanding, the outcome is most successful when it's combined with another treatment. So you'll combine something like PRP with minoxidil. I think the good provider who does PRP will, I think, be really honest about the possibility of success. I think there are a number of factors that make someone a better candidate for this, and something that makes someone not a very good candidate. So the improvement varies pretty dramatically. Some studies showed it as low as 25%. I think some studies show that it's a lot higher, but I think patient selection is probably a really important part of that whole picture. I would love for you to add anything that you would like on that.
Yeah. So we interviewed Dr. Joanna Hooten at Clara Dermatology in Cary, and she really reiterated basically what you said, but a couple of things. So if you're not familiar with PRP, it's platelet-rich plasma. So you're drawing a blood sample from someone, spinning the sample down, collecting the platelets. The platelets are very nutrient dense and they're very helpful for healing, and then injecting those into the scalp. And so one of the things that she said that was really a common problem in PRP was that if you're injecting in someone's scalp, it hurts. And so you would, trying to be a nice person, you try to pick the smallest needle. But the problem with a really skinny needle is that you can lyse the platelets. You can break them because they're being forced through a tube that's too small. And then it's kind of a waste. And so she was talking about needle selection is really important. And then to your point about patient selection, if someone, let's say, has either androgenic alopecia or chronic telogen effluvium, and they're earlier in their process, right? So if someone has had hair loss for 45 years, PRP is probably a waste of money. If they've had hair loss for 2 or 3 years, then probably it's really worth a good try. But then, working with someone who's an honest practitioner, who's not just going to take your money and is saying, hey, I really think I have a chance at helping you versus not. But she talked about needle selection and then duration of the problem.
Yeah.
So moving on to holistic, what's next in the holistic things we can try?
Yes. So we have a lot of, you have a lot of patients that come in on Nutrafol, so the commercially available product. One of the big ingredients in there is saw palmetto. And studies that I believe the company did them showed that it improved hair growth in individuals with telogen effluvium.
Interesting.
So I know. So, and my question with those studies is, would that telogen effluvium have improved anyway if it was related to an illness or a stressful event? And so, I think, in my opinion, I still have questions about using these products, these combo products. We do know that saw palmetto can be helpful in typically androgenic alopecia by its impact on the conversion of testosterone to DHT. And so I think that's a reasonable thing to try with someone. You generally need to be dosing it relatively high. You want to stay in a safe range, but dose it relatively high. So, doing a really baby dose of saw palmetto probably isn't going to do much specifically for hair loss. But I think that's a reasonable supplement to try. There are some combos that we use that have nettles and included, and both of those are working to block that conversion of testosterone to DHT and help at the receptor site too. So I think that's a reasonable thing. I don't see that as the game changer for a lot of patients. I don't know what your experience is, but
yeah, I see a lot of women that take Nutrafol. I don't necessarily recommend it. They're afraid to go off of it because they're afraid their hair loss will get worse. But I think you brought up something that I just want to make sure people hear. So good news, if you have telogen effluvium, it will most likely go away if you do nothing in 6 to 12 months, right? So telogen effluvium generally resolves on its own. It's super frustrating, and it's super frustrating. We get it, to be a patient and for your healthcare provider to be like, oh, it'll be fine. And you're like, my hair is falling out in buckets. It's not fine to me. But telogen effluvium usually goes away on its own. And then I think Kate alluded to this. So Vital Nutrients makes a sting nettle saw palmetto pygeum formulation. So in our more holistic leaning practice, let's say we met a patient who had been on spironolactone and maybe she had sexual health problems, or maybe it lowered her blood pressure too much, can really make people dizzy. Then we might put them on that as a sort of natural androgen blocker that might help. So, yeah,
I think worth a try, and usually a pretty low risk option. In terms of topicals, there are a couple of topicals that I think are really worth exploring. Pumpkin seed oil, so pure pumpkin seed oil, 1 milliliter nightly to the scalp. And again, you run into the issue of you're actually putting oil, not just a solution, on your scalp. So this means you probably need to wash your hair more frequently. But this had, when it was compared with minoxidil in studies, it performed less well than minoxidil, but it still had a significant impact on hair growth. So if you're someone who is not comfortable with minoxidil for whatever reason, pumpkin seed oil would be a more natural option. Again, you're talking a 4 to 8 month commitment to see if it works every night. But I think pumpkin seed oil is worth checking out. Melatonin topically actually has an impact on androgenic alopecia. So
it's anti-inflammatory, right?
Yeah,
it's
it
anti-inflammatory.
is. Yes. And so a 0.1% melatonin, 1 milliliter daily. I don't know of a commercially available product for this. I know there are liquid melatonins. I've never had someone use an oral product topically. So I would probably have this compounded at a compounding pharmacy into a solution or a foam. But I think that's another option that is a potential. As far as I know, there haven't been studies on oral melatonin for hair loss.
Right.
So I can't speak to whether or not that would be helpful. Caffeine is another option as well. Again, you can maybe just put your coffee on your hair, but topical caffeine has pretty similar outcomes to minoxidil.
Okay.
These are small studies, but I think that's a really promising option. You want to get about a 0.2% formulation, and you should be able to get that over the counter. I think an option to try. There was one study that actually looked at minoxidil and caffeine together, and the outcomes were better than minoxidil by itself. So maybe you wash your hair with a caffeine containing shampoo, leave it on for a couple of minutes, and then also do minoxidil once a day. So that could be an option to sort of combine a more sort of integrative approach and also a conventional product.
Right. But I could see you working with someone and compounding caffeine with maybe not all the garbage in it, minoxidil plus maybe some melatonin, and just saying, this is a hard problem to fix. We're just going to put as many tools in our toolkit as we can.
Yes. Microneedling is an option too. Studies basically say this might work when combined with other therapies. So that's where it appears to really be the most successful. Microneedling is this process that needs to be done by a trained provider, but where you basically are stimulating the tissue by putting small needles into it. And so you're working on stimulating hair growth that way. And I'm actually, I will say, I'm not sure if the microneedling is then followed up by minoxidil, and so that's the mechanism, or if they're just both being used if you do microneedling and then also just use minoxidil. So I'm not sure of the proximity of how close the minoxidil needs to be applied after the microneedling. So I would talk to a provider who provides microneedling about that.
Well, sometimes in dermatology, right, if we're trying to get serums and things into the face, they'll do a microneedling just to improve the absorption of whatever you're putting on next. So that kind of makes sense, but that would probably fall under the realm of a dermatologist.
Yes.
Okay.
And then the last thing, I mean, we talked about PRP or platelet-rich plasma, but low-level light laser therapy is a potential too. Peter Attia, if anyone's a Peter Attia fan, talked about this on the drive. Studies do show a positive outcome. I think that the downside of these is that they're expensive. And so worst thing that happens is you spend money on an expensive product that may or may not work, but really a very low risk option otherwise. So it's not putting anything into your body. It's not putting a solution on your body. It's just using light, laser light to stimulate hair growth.
Right. I think red light therapy, I want to say like 780 nanometers, but I'm pulling it out of my head, so that could be wrong.
Yes, I don't have that number. Peter Attia talks about the brand Caprilis. That was what he recommended. I don't have any personal experience with that product, but that was, I believe, what he recommended.
If folks are listening in our membership program and open office hours, we have a whole session on red light therapy and kind of talks about all these products and the wavelengths and all the things. So if you're taking advantage of that, that's available there.
Yeah. Wonderful.
I have one last question. This has been so helpful. Thank you so much. So a lot of times when you kind of alluded to this, we are going to lose more hair when we wash our hair. And so sometimes when women are coming in and they're saying, hey, I'm losing hair, and I like put on some gloves and I look through, their hair is full of dry shampoo. They have not washed their hair for a week or more. And, I feel like if we are identifying inflammation as a potential problem, at some point, letting the hair get get that kind of buildup of product off. So do you have like advice on people, like dry shampoo is great and we're all busy and we're professional and we're trying to get out the door? Like, and you still need to wash your hair twice a week. Do you have any feedback on that? I mean, obviously there's going to be some differences, but
yeah, I think for most individuals, and I would say African Americans, I would put in a less frequent washing
sure.
category because we're wanting more oil typically on the scalp.
Mm-hmm.
But for hair like mine, ideally we don't want everyday washing because it does strip the hair of some of the natural oils that are helping keep that scalp microbiome in a good place. But we also, I agree, I want to see people washing, maybe twice or 3 times a week, because we don't want a lot of buildup of product. And so, if we can let our scalp sort of figure out, what's the balance of oil production, and some people are just going to need to wash their hair a little more often to keep things at bay. So I think there's a fine balance to strike, but I think the buildup of product is probably not the most helpful thing in terms of lowering inflammation on the scalp.
Yeah, absolutely. Well, this has been fantastic. So hopefully people leave here with, if you're having hair loss, I would say really low hanging fruit, get your ferritin checked, get your thyroid checked, get your vitamin D checked. There are plenty of things you can try to do at home. If that's not working, working with a dermatologist that really has an interest in hair loss. And I think, everybody deserves to feel heard here. I think one thing you've emphasized so clearly is that when people really start to notice a clinical difference, they've already lost quite a bit of hair. And so the patient coming in and saying, hey, this is different to me. And you and I may be looking at them thinking, you have a beautiful head of hair. What you worried about? That we really need to pay attention to that. So thank you so much for really reminding everybody that they deserve to be heard and that this is really an important area. They're all important areas to hear the patient, but especially this one.
Yes, absolutely. Well, pleasure to be here. Thanks for having me.
Thanks so much. Have a great day.
Bye.
Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? And is a quick and easy way to learn more about our practice and what it has to offer. Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider. The content of this podcast is not intended to be a substitute for professional medical advice. Listeners should not disregard or delay in obtaining medical advice for any medical condition, and they should seek assistance from their healthcare professionals.